Greetings from InCars. So as we enter 2025, we start our e-classes. And for the first e-class, we have a case presentation by Dr. Sanjana from Andhra Medical College. And we are honored to have esteemed professors, Dr. Jyotsna, Dr. Srinivas from Jayadeva Institute. And also we have an interesting talk from Dr. Naveen Matthew from Amrita Institute, Kochi. So we'll start right away. Dr. Sanjana, can you present the case?
Yes, ma'am. Good evening, esteemed faculty. Thank you for giving me this opportunity. I start my case presentation now. A 22-year-old female by name Y. Jyoti, who has studied until 10th standard from Adanampudi, Vizag, who is a housewife from low socio-economic state, came with chief complaints of joint pain since 1 month, shortness of breath since 15 days, pedal edema associated with facial puffiness with abdominal distension since 10 days, anorexia and nausea since 10 days. Coming to history of present illness, patient was apparently asymptomatic 1 month back when she developed joint pains. Joint pains first started at the ankle, associated with swelling, which was about 5 to 7 days, and later progressed to knee joint, and which was also involved with swelling. And since the past 3 days, patient also history of swelling swelling and pain involving the small joints of upper limb, that is and also pain in the shoulder and wrist joint, but not associated with swelling. This joint pains is also associated with low grade fever. Now patient has only swelling and joints of the upper limb, whereas the swelling and joints of the ankle and knee have subsided. Coming to the next symptom, there is history of shortness of breath since the past 15 days. Insidious onset gradually progressive from NIHA 3 to NIHA 4 in 10 days, associated with orthopnea, which is also associated with cough with sputum, which is whitish in color, non-foul swelling, scanty in quantity, more on lying down, and subside on sitting. And with the above complaint, she came to hospital, and now she is in NIHA 3 after admitting at the hospital. And also, patient had developed pedal edema, which was insidious onset, gradually progressive, started at the feet and progressed to the thigh, that is grade 3, in 10 days, which was associated with facial puffiness and abdominal distension. There is history of palpitations on exertion since the past 20 days, which was regular, increased on exertion, relieved on taking rest for 10 minutes, and there is no history of post palpitation diuresis. There is history of anorexia associated with nausea and vomiting since the past 10 days. Vomiting which contains food particles, not associated with any hematemesis. In view of the above complaints, patient went to a local doctor where she was given medication, and she was sent home. And later, after taking medication, there was increase in urination, and associated with she developed generalized weakness and fatigue, and then came to our hospital. There is history of fever since the past 3 days after admitting the hospital, which was more during night, high grade, associated with chills, and subsiding with medication, intermittent in nature. This is about the positive history, and there is no history of hemoptysis or syncope. There is no history of hoarseness of voice and difficulty in swallowing. There is no history of limb weakness, altered sensorium, slurring of speech, or diminution of vision. There is no history of decreased urine output or any rashes. There is no history of any penicillin usage. Coming to past history, there is history of multiple joint pains 1 year ago, involving joints of both upper limb and lower limb, associated with fever, which was more during night. And she was admitted at our hospital, a general medicine department, and joint pains with fever subsided with medication within 1 month. There is no history of any cardiac complaints during that episode. There is no history of any relevant past history also, like hypertension, diabetes, asthma, thyroid disorders, or bleeding disorders. Family history, she is first among 2 children born out of non-consanguineous marriage, normal birth and developmental history. Menstrual history, she attained menarche at 14 years of age. 6 by 30 day cycle, menorrhagia present since the past 3 months. 3 children of age, last child is 4 years of age, at hospital institutional deliveries, uneventful pregnancy, and vaginal delivery. Personal history: consumed mixed diet, appetite is normal, sleep is reduced due to shortness of breath and cough. Bladder and bowel habits are regular, no addictions. Drug history, probably diuretic. Probably she's taking some medication which are probably diuretics since the past 10 days, since the past 5 days. Coming to the summary: 22-year-old female with migratory polyarthritis with symptoms of subacute onset of left heart failure and also right heart failure associated with constitutional symptoms. With the above history, my possible diagnosis would be first would be left-sided regurgitation lesions of mitral, may or may not be aortic valve, secondary to rheumatic etiology. Second diagnosis would be viral myocarditis. Third would be left-sided valvular regurgitation secondary to infective endocarditis. And fourth would be chronic heart failure, reduced ejection fraction, which was asymptomatic with acute decompensation secondary to infection.
Hello, Sanjana.
Yes, ma'am.
Yeah, it's a nice presentation, but it requires a few clarifications and modifications.
Yes, ma'am.
History-wise, when you are presenting it, you said a significant polyarthralgia, even at present, even though there is no arthritis, but you said the only constitutional symptoms when you are concluding the summary. Is relevant? Because in a case of rheumatic and heart disease, when the patient has an active polyarthralgia, that itself is taken as one of the major criteria.
Yes,
so then how can you say that is a constitutional symptoms? That is the first question. Second one, when you are talking about the pedal edema, you classified as a class 2. Is the pedal edema is classified as a class 1, class 2, class 3? You require modification for that also. And the third one is an important one for you to say in a summary is that is patient had then polyarthritis before and now has the right and the left heart symptoms. But what made you to think it is a regurgitant lesion but not a stenotic lesion? That in the history itself you have to mention about it. Like the patient has the exertional palpitation, which is getting the relieved with that. So what made you to think it is a regurgitant lesion? That has to be reflected in the summary for you to say the regurgitant lesions. So you wanted to answer all these things?
Yes, ma'am. First thing, ma'am, she has polyarthritis, ma'am, pain associated with swelling and redness. And in my view, constitutional symptoms, I was referring to anorexia, nausea associated with the right heart failure, along with the fever, as you rightly said about polyarthritis. And second, pedal edema grading is for pedal edema, ma'am. Like grade 1 is up to ankle, grade 2 up till knee, and grade 3 more than thigh, and grade 4 is anasarcoma. And the third one, why I said regurgitant lesions is she is 22-year-old female with history of polyarthritis associated with sudden onset of subacute onset of left-sided heart failure within 1 month. So generally, stenotic lesions are a bit more long history about when you take mitral stenosis. It will take about 5 years to have, and gradually progressive. Whereas regurgitant lesions, when there is an acute rheumatic episode or when there is an infective endocarditis episode, they are rapidly progressive or subacute in onset. So my first thought would be regurgitant lesions instead of stenotic lesions because of the short duration of the symptoms. And also, according to
there are the two ways of saying the possible causes. One thing is a positive history and the second one is a negative history. So don't go for the negative history in the beginning. So first if to say the regurgitant lesions, what are the classical features of the regurgitant lesions? Is the type of the palpitations and nature of the progression of the disease. So if that is consistent with the natural history or not, then why you don't want to say the stenotic is different? Isn't that the stenotic lesions doesn't have the acute presentations? What are the conditions in a stenotic lesions where you can have a acute pulmonary edema?
If it is a new onset AF, then they can present with acute pulmonary edema, madam, or any acute atrial tachyarrhythmias, or any acute pulmonary embolism, or RV fail, or RV ischemia secondary to mitral stenosis.
Infection, pulmonary embolism, and
AF.
rarely an embolism and also coronary embolism is also. But
Yes,
as you said, the infection is the common cause, and the atrial fibrillation, any type of the atrial arrhythmias, more frequently atrial fibrillation can precipitate. So that can't exclude you to say the short history. That's what I mean to say it. That's why whenever you wanted to say conclusively, I consider the regurgitant lesion. At that too, the left side regurgitant lesion is more likely. And why not a mitral versus an aortic? That is also has to be the told. Because what is the difference between the left heart failures of aortic versus mitral?
Mitral aortic first, mitral regurgitation, they more commonly present with shortness of breath as the first symptom, ma'am. Whereas aortic regurgitations, first symptom would be
The
mostly
major,
palpitation.
that is not the way to express it. The thing is, the mitral valve, for the aortic valve, when there is an increase in the left ventricular diastolic pressure, there is another protective valve, the mitral valve, to transmit these pressures directly to the left atrium, to the again to the pulmonary capillary wedge pressures. So
Yes.
there is one valve which is protecting it. Whereas that is not there in the mitral regurgitation, because directly the pressures are then transmitted to the pulmonary capillary wedge pressure. So the more fulminant course and more frequent severe symptoms are known to then occur. But it doesn't mean to say that an AR doesn't have it, but only MR has it. But this is a relatively the features which are the present. So these features you have to say that why you wanted to consider the regurgitation, why you wanted to consider mitral more than the aortic. In that way, it should be there. And viral myocarditis, second cause you wanted to consider, who has the previous history, the in your hospital only admitted with a previous history.
And let's stop, make Dr.
Hello.
Hello. Dr. Sanjana?
Yes, ma'am. Yes, sir. Sorry.
Yeah. Fine. Yeah, I think the problem with the audio. Yeah.
Yes.
As Dr. Madam is telling, we'll have to consider the stenotic lesions also, because it's already, she's 22-year-old and had some events a year ago. And we don't know whether the person had silent rheumatic fever without manifestation earlier in the second decade. So, and as the left atrial pressure, high left atrial pressure symptoms are dominant, mitral valve disease, and including a stenotic lesion, you cannot do away with. So we'll have to put it as mitral valve disease.
Yes.
Then, of course, additional, because you said a lot of palpitations, etc., you can bring in the aortic valve disease. And again, on the same note, the right-sided involvement also you cannot rule out, though it is early in life.
Yes.
As you have said, all the even with the left heart lesion, developing the right-sided symptoms, it takes long time. When
Yes,
it moves so rapidly, you will have to keep in mind the possibility of organic right-sided valvular involvement also.
Yes.
Yeah, as sir brought out a good point. Do you consider that the left heart symptoms like a pulmonary edema can happen with the tricuspid valve, primary tricuspid valve involvement?
Primary. I'm not sure.
Yeah, but that is rare. But
Rare.
in rheumatic, it is more commonly the tricuspid valve stenosis occurs in the case of mitral stenosis much more frequently than an isolated the tricuspid stenosis. There is another causes than the rheumatic and heart disease to produce it. So once you have a left heart symptoms, it has to be the left valvular heart disease, which is leading to additional right heart and symptoms also. If the patient has an improvement of the symptoms, of the pulmonary edema and now the predominantly the right heart failure, then definitely you will consider then
Mitral
associated tricuspid stenosis or
Stenosis.
the regurgitation. Most likely stenosis is likely to be the possibility. And one
Yes,
more important past history you are not highlighted is the rheumatic history. You took very lightly and you're not highlighted much about the past history. So another point you have to add in your diagnosis after the clinical history is whether it is an acute exacerbation of a rheumatic activity or infective endocarditis or some other condition has to be ruled out, which you are already mentioned, but you are not talked about an acute exacerbation because we require natural history is entirely the different when this age group at 22 years to have the another episode of the rheumatic fever to present as a polyarthritis. I think with the limitation of the time, sir, can we go ahead for the clinical examination?
Clinical
Srinivas?
feature. Yeah, we can go ahead with the further discussion, no problem.
Yeah.
yes. General examination. Patient is well-built, ill-nourished. There is pallor. There is no signs of ichthus, cyanosis, clubbing, or lymphadenopathy. Bilateral upper limb, interphalangeal joints, and metacarpophalangeal joints swelling present, associated with tenderness and redness. And bilateral shoulder joints, tenderness is present. There is no swelling. Height is 152 centimeters. Weight is 40 kgs. BMI comes about 17.3 kg per meter square. Upper limb lower limb ratio is normal.
No, keep it there. And is that is anything is in favor for your diagnosis of the valvular regurgitation you are considering? Left side valvular regurgitations, anything positive finding you got in the general examination?
Not much, ma'am. For
What do you expect? Or otherwise, if it is MR, what do you expect?
I'm not sure.
Anyone else, if any, for these questions, someone can answer in the chat also. Yeah, please go ahead. I will wait for the other people to answer.
If any infective endocarditis is present, clubbing will be present.
Okay.
And
okay, go ahead.
Cyanosis may be present in severe MS due to peripheral vasoconstriction.
But that is not a central cyanosis, no? You meant it, the cyanosis is a central cyanosis.
Yes, ma'am.
Yeah, of course. So go ahead for the next slide. We'll wait for the answers if anyone gives. If not, then we can discuss in the end. Go ahead.
Yes, ma'am. And there is no rash, and there is no evidence of any rash or subcutaneous nodules in general examination, ma'am. Vital signs. On examination, patient is conscious, coherent, cooperative. Patient is febrile. Pulse rate is 112 beats per minute, regular, high volume, rapid rise, collapsing. No radioradial and radiofemoral delay. All peripheral pulses felt. Normal character of vessel wall, and pulses bisference is present, ma'am. And blood pressure, right upper limb 100 by 40 0, left upper limb 100 by 40 0 of Hg.
Don't move the slide. What is important slide, you keep that slide. Once you finish, then you go to the other slide.
Okay.
Yeah.
Right lower limb 150 by 30 0, left lower limb 140 by 0. Saturation 95% in all four limbs. Respiratory rate 17 per minute. Hill sign present 50 mm of Hg. Peripheral signs, Landolfi sign present, Durosis murmur present. Pistol shot sounds are present. Jugular venous pressure, which is elevated 8 centimeters above sternal angle. 2 positive waves and 2 negative waves present, and A waves are prominent.
So what is the conclusion of this clinical examination?
This clinical examination, there are peripheral signs of AR are present, and all the peripheral signs suggestive of severe AR, that is Hill sign present, and diastolic pressure is reduced, is almost like muffled at 40 and able to be heard at, until 0. And
that is everyone knows all the peripheral signs of AR, so we are not going to ask on that. What else important information you got it? What is the severity of the AR?
Severe AR.
Why severe?
Hill sign is 50 mm of Hg.
How
Generally,
do you classify depending upon the Hill sign, the severity of the AR?
Yes, ma'am.
Tell, how do you classify?
Oh dear, sorry, I couldn't hear him. 20 to mild AR, 20 to 40 mm of Hg. Moderate AR,
Mild is
20 to 40. Moderate is 40 to 60, and severe is more than 60 mm of Hg.
of hillside.
Hillside, yes, ma'am.
Okay. So this comes under, then why you said the severe? 50 to 60, according to more than 60. Yeah?
Yes, ma'am. But all the peripheral signs are also present. So, considering moderate to severe and also with peripheral signs, I think it is.
See, the only thing is correlates with the hillside,
Yes, ma'am.
with the severity.
Yes, ma'am.
And the presence of all the peripheral sign doesn't mean that it is has to be the severe. Suppose associated other anemia is there. You already said the patient has a pallor.
Yes,
so that
ma'am.
may be the contributing. So then you will have all the peripheral signs. So that's the reason you have to be very specific when you're telling about the severity. That is a hillside. Dr. Srinivas, you want to ask anything on the clinical signs?
Just fine.
Bisphorins also. Yes, sir.
Patient in a low output state, the systolic blood pressure is quite low in the background. Yeah, but still you can well say moderate to severe AR. So you should, I mean, by definition, you can say moderate, definitely.
Yes.
But in the back of your mind, you will be thinking that it could be severe when you go for the investigations.
So
Yes.
that's another important point. There is a systolic decapitation. What does that mean? Why there is a systolic pressure? If it is a pure AR, you should have then systolic hypertension. On the top, there is systolic decapitation. So what is the cause?
Maybe acute rheumatic activity. Might also affect the myocardium and cause LV dysfunction, which can also cause systolic decapitation, leading to less systolic pressure.
What is the what will happen? Sir, please ask.
More important than that, because you are described your first initial symptoms or shortness of breath and all those things. So, which is more indicative of mitral valve disease, of raised venous pressures.
Yes, sir.
Significant mitral stenosis would be the first thing that you would think of in this scenario, no?
Yes,
Rather
sir.
than a rapidly developing LV dysfunction.
Yes, sir. Could be a
And
possibility.
one more important point, if you're thinking of an LV dysfunction, the first thing is gradually what will happen is all peripheral signs of AR will go off. So in the presence of this significant peripheral runoff signs, systolic decapitation, you can't consider that the LV dysfunction is responsible for that. As sir is saying, associated valvular heart diseases has to be brought into the thought. Yeah, please go to the next slide.
Yes.
Everyone knows AR signs, so we are not going to ask about it.
Systemic examination, inspection and palpation combined, chest symmetrical, trachea central, apex beat, left sixth intercostal space, lateral to mid-clavicular line, hyperdynamic type of LV, hyperdynamic LV apex, parasternal heave present, grade 2/3, palpable sounds present, LVS3 palpable P2 at left second intercostal space, systolic thrill present at the apex, there are visible epigastric pulsations, and there are no stars or sinuses.
So what is the positive things? You said the severe AR is more likely with the clinical examination, but as well as the valvular or the LV dysfunction, you wanted to see about it. So anything you got a positive finding for it?
Yes, ma'am. LV apex and volume overload type of LV apex with RV hypertrophy is present, and there are palpable LVS3 and P2 suggestive of left heart failure or mitral regurgitation.
P2 doesn't suggest of a left heart failure.
Oh, ma'am, LVS3.
LVS3. So, okay. You
LVS3.
think in LVS3 is suggestive of the left heart failure?
It is suggestive of left heart failure or a severe MR, or it's a sign of severe AR also.
Pure AR can have a LVS3?
Severe AR can have an LVS.
Okay, if you think that is in a left heart dysfunction, then why you have a hyperdynamic LV apex? What is the type of the apex you expected?
Normal.
No, LV dysfunction. What type of effects? I'm not getting anything in the chat. One person is a pallor with clubbing, madam. Yeah, that's good. What is the type of the apex we expect if it is an LV dysfunction? It becomes a sustained. It
Yes.
will be the normal, even though the AR is responsible for the patient's LV dysfunction, then all the peripheral signs of AR will go, and hyperdynamic LV will become a sustained.
Yes, ma'am.
You can suspect they're associated. Okay.
Yes, ma'am.
Palpable P2 and parasternal heave of 2/3. What that suggests?
Pulmonary arterial hypertension, ma'am.
Or likely grade.
Moderate to
P-
severe pulmonary arterial hypertension.
Okay. Because in the inspection, we suppose not to grade the pulmonary arterial hypertension, because it's mainly the loudness of the P2 will decide the severity of the pulmonary arterial. Any questions, sir, here?
Yeah. So your presence of S3 also rules out a significant mitral stenosis.
Yes, sir. Yes.
Obviously.
Yes, sir.
And you said systolic thrill at apex. It is an additional findings, which
Yes,
you didn't expect it to be present in a, you are expecting everything is in a pure AR. And
yes.
LVS3, that's why you have to say that there is systolic thrill. I think that is an MR is responsible for the LVS3 than saying the LV dysfunction. It is a simple way to say it, or otherwise all your findings will go off.
Yes, ma'am.
Your sustained effects has to come, all peripheral signs has to go off. Okay.
Yes, ma'am.
Yeah, please go
What
ahead.
else
Next.
will you think of? See, MR and AR is a combination. It's systolic decapitation. So just we can't put it just on the LV dysfunction here. Okay,
Yes.
so mitral stenosis is almost ruled out because your S3 is palpable.
Yes, sir.
So what other thing can you consider for the systolic decapitation? Some obstructive lesions you will have to bring in. It may be the right-sided obstructive symptom or lesion also.
Commonly, AR can be associated with what?
You said the A wave is prominent in your initial description. So with that, maybe we will have to keep in mind the possibility of TS.
Yes, sir.
Okay, please go ahead.
Percussion, right sixth intercostal space, river dullness present. Left second intercostal space, dull, about 6 centimeters. Right heart border corresponding to right
Just a moment. Your epigastric pulsation, you said you did not elaborate on that.
Visible epigastric pulsations and after palpation, RV type of epigastric pulsations present.
RV type of
epigastric pulsations.
Yeah, actually, there are now the people started responding. So mitral LVS3 is not because of an LVF, because of an MR, that is good. And LVS3 in AR indicates an LVF, madam, is yes. LVS3 in a pure AR usually suggests an LV dysfunction. Okay. Yeah, please go ahead.
Right left heart border correspond to line joining apex and left second intercostal space. Auscultation suggestive of pulmonary percussion findings suggestive of pulmonary hypertension. Left second intercostal space is dull. The rest all findings correlates, and auscultation S1 is soft, S2 loud P2 and normal split. LVS3 present, which is low pitch, best heard with bell of stethoscope, while expiration there is no S4, no other added sounds. Coming to murmurs, early diastolic murmur, grade 2/4, high pitch, soft blowing, decrescendo, best heard with diaphragm of the stethoscope at right second intercostal space, with patient sitting up and leaning forward in position in deep expiration. This is the first murmur, suggestive of an AR murmur. Next murmur is pansystolic murmur, grade 4/6, high pitch, soft blowing, radiating to axilla, best heard with diaphragm of the stethoscope at apex in left lateral position and on deep expiration. Another murmur, mid diastolic murmur, grade 2/4, best heard at apex, not radiating, short without presystolic accentation, low frequency sound, best heard with bell of stethoscope. Suggestive of flow murmur. These are the three murmurs.
So you commit your diagnosis so that we can cross-check your auscultatory findings.
Yes, other systems are normal. Final diagnosis, acute and chronic rheumatic heart disease in the form of severe AR and severe MR with moderate tricuspid regurgitation and severe pulmonary artery hypertension with severe pulmonary venous hypertension in heart failure stage D in sinus rhythm with a rate of 112 beats per minute in NIHA 3 with acute rheumatic activity plus or minus infective endocarditis without embolic phenomena. Final
So
diagnosis.
now, yes, sir.
Anemia, pallor, you said pallor, no, in the
Yes,
initial
with
description.
pallor.
General definition. Yeah,
With
so anemia also you should include.
Yes, sir.
So now you substantiate. Why you said a severe aortic regurgitation?
Severe aortic regurgitation because pulses bisphorus is present, hill sign is present about 50 mm of Hg, that is suggestive of moderate to severe.
So now we are
Yeah.
going to talk about in the presence of the severe MR, what are the changes that can happen in the signs of the severe AR?
Yes, ma'am. Next, LV type, volume overload type of uppets, down and out, and rate 2/4 early diastolic murmur suggestive of severe AR, which was which occupies total of diastole and early peaking and occupies total of diastole suggestive of severe AR, and the severe MR because there is findings of LVS3 present, grade 4/6.
No, don't combine. I asked you severe AR, you are continuing the severe AR. Now
Yes.
my question is, in the presence of the severe MR, what are the modifications or changes you expect in a assessment of the severity of the aortic regurgitation?
Okay.
Do you expect or don't you expect?
We expect, ma'am.
Why?
Um,
Mitral regurgitation is during the systole, aortic regurgitation is during the diastole. Why you expect the changes? Explain it.
With mitral regurgitation, LVEDP rises more when compared to only severe AR. So all the signs of aortic runoff are exacerbated. So
Why exacerbate? If the LVEDP is raised, please, you have to be very clear in your way of presentation. If the LVEDP is raised, so the gradient between the left ventricular diastolic pressure and the aorta is coming down. So the severity of the AR has to come down. You are saying that it is going to exaggerate.
oh, sorry. Sorry, ma'am, but
So
LVDP raises.
basically severe MR is not going to have an effect unless it has an effect on the left ventricular and diastolic pressure. That is mean to say that it is started in an early left ventricular dysfunction. Yes, then it is going to have an effect. Otherwise, as I said, it is a systolic is a regurgitation in the mitral and the aortic regurgitation the diastolic. So basically the volume overload because of the MR, next bit is going to have an increase. So because of the increased volume or overload, there will be exaggeration of the symptoms. One exaggeration of the aortic regurgitation symptoms because forward outflow increases, as well as the percentage of the regurgitation also increases.
Yes, ma'am.
So in that way it increases. But once the left ventricular and diastolic pressure starts rising because of the MR, then the signs will come down.
Count. Yes, ma'am.
Okay.
Yes,
so
ma'am.
now you have to, when you are saying about two severe valvular heart diseases, you have to be very certain that interaction is known to then occur in the both of them. So when you are saying the signs are present or not, then you have to think with the second things, like a very soft one. Second heart sound is a very, very important one, which you pass just like that, which is the key for then everyone. Every valvular heart is every cardiac auscultation is that. So you said the loud P2 is not sufficient enough. You have to mention how is the A2 is also. How do you expect what is going to be the A2? In the A2 P2, what will happen in the mitral regurgitation and the aortic regurgitation?
In mitral regurgitation, the split becomes wide fixed split, ma'am. Because of pulmonary hypertension, the P2 A2 comes early, and because of the backward flow to the LA and forward flow is decreased, so A2 comes early and P2 is delayed because of pulmonary hypertension. So there is wide fixed split of S2 in mitral regurgitation. Whereas in aortic regurgitation, because the forward flow is also increased and the pulmonary hypertension is also increased, the split is normal or but not very wide fixed split.
What is going to happen is the sounds of A2 and P2.
P2 is loud in mitral regurgitation, whereas A2
Maybe,
is soft
the pulmonary arterial hypertension
in
occurs.
pulmonary
And
hypertension.
what happens to A2 in aortic regurgitation?
A2 is also loud in aortic regurgitation because
Why
forward
it
flow.
will be loud? Only in the case of the what is type of the aortic regurgitation where the loud A2 can happen. Usually the softening of the valve then occurs, wall sounds can occur. Only then if there are the few exceptions where the wall sounds can be exaggerated in an AR. What are those conditions?
Syphilitic AR, there is loud A2 and tambour quality of the A2 is present, ma'am. Or if any perforation of the aortic valve is present.
Don't go there. The perforations doesn't causes it. As you said, the timbre quality can give the impression that it isn't loud, or otherwise it is going to become a softer. So if the A2 becomes a softer, that gives a clue to the severity of the AR.
Yes, ma'am.
Okay,
Yes,
that is one thing which you are not highlighted. So the severe, why you said the severe mitral regurgitation?
Considering the facts like LVS3 is present and pansystolic murmur grade 4/6 associated with thrill is present, and mid-diastolic murmur without any presystolic accentuation, that is suggestive of a flow murmur across the mitral wall, which can point towards severity of MR. And there is also RV hypertrophy and severe pulmonary
Don't go for secondary signs. These are the primary signs.
primary.
Excellently, you highlighted that you are not told that left ventricular apex. I am happy because when the presence of the AR is there, if you take as a left ventricular dilated, then LV is can't be a criteria. You
Yes.
took a flow murmur, that is good, and you took in the presence of the pansystolic murmur. But of course, many people will say that there is no correlation between the severity of the MR and the severity of the systolic and murmur. But most of the time, clinically, what we see is associated with that. Even though
Yes.
theoretically it is possible that variation can happen. Other important one is the flow murmur, you said. But
Yes.
another important one is the split of the nest, which is going to be helpful. In this case, it is not there.
Not
Can you
helpful.
explain why it is not there?
Because of associated AR, which increases the flow across aortic wall. The early occurrence of A2 doesn't occur. So A2 is also prolonged. So this causes a normal split when associated with AR and MR.
Okay. So then why there is a severe pulmonary arterial hypertension? Sir, you can also ask the questions. Just to keep the ball rolling, I am asking that, sir.
Yeah. Continue, ma'am.
Why it is severe pulmonary arterial hypertension?
Because loud P2 is present and on percussion, the left side intercostal space, that is pulmonary area, is dull, about 6 centimeters. That suggestive of severity, and also
No, in this way, you are not telling properly. Like an MR, you told properly, but severity of the pH, you are not. The first thing is the loudness of the P2 will decide. That's why you have to say that the P2 is loud at the pulmonary area is not sufficient enough. You have to tell how is the P2 at the apex. If you are able to heard the P2 at the apex, means it is a severe pulmonary arterial hypertension. If it is heard only exaggerated but not equivalent, then it is a mild. But in the second intercostal space, it is equivalent, then it is a moderate. So that severity of the pulmonary arterial hypertension depending upon the P2, where it is heard. If it is heard as an apex, means you can be very certain that it is a severe pulmonary arterial hypertension.
Yes, ma'am.
What is the effect of the pulmonary arterial hypertension on the split?
With pulmonary arterial hypertension, the P2 is the handout interval increases, so the P2 is prolonged, so split also increases, ma'am. Wide split occurs. Wide variable split occurs with only pulmonary arterial hypertension.
There is some questions how to check the Bispherians pulse. Can you say?
At the best palpated at the brachial and also at the aortic I'm sorry, aortic pulse.
So
yes, sorry,
first we
aortic
take
pulse,
the site of the palpation should be at the brachial. Okay, good.
site of
Then
the
what? How,
palpation.
the question is how do you feel the Bispherians?
At the brachial artery on palpation during systole only, correlating with the apical impulse. At the systole only, you feel two peaks. That is suggestive of a bisference pulse.
Okay. What is the other question? Bispherians in HOCM versus AS versus AR. I could not understand the question. Probably they can reframe the better way. Sir, can we go ahead, sir?
Yeah.
Should I go forward, ma'am?
Yeah, you can
You
continue.
wanted to show the ECG or echo? Which one you wanted? ECG, echo, X-ray?
First ECG, ma'am.
Why you prefer a ECG over an X-ray?
ECG gives us findings of whether there are LV hypertrophy and RV hypertrophy findings are.
So do you expect in AR and MR will have a different types of the hypertrophies?
No, I mean.
Then how it is going to be the helpful?
Not that.
Yeah, actually the X-ray should be the much better to know the severity of the both the bollar lesions than an ECG. Anyway, go ahead with the ECG. What are the findings?
ECG, sinus, normal standardization, sinus rhythm, rate 120 beats per minute, regular.
And the important thing you are not told is the heart failure. Sir pointed out in the beginning, raised JVP with a prominent A wave, you said. And in the final diagnosis, you are not mentioned about heart failure.
Heart failure, I mentioned. Stage D heart
Yeah,
failure.
okay, good. Okay, go ahead.
Sinus rhythm, rate 120 beats per minute, rhythm regular, normal standardization, P wave normal, P wave axis.
And one more thing, sir. Actually, I'm
normal.
not concentrated in the heart failure. You gave the description of the tricuspid valve regurgitation also, where you said the increase in the inspiration, all those things doesn't happen in the heart failure. Because there is no further inspiratory rise of the flow doesn't happen. So you don't have the murmur variations in the case of a heart failure.
Yes, ma'am.
So there are the few points which are left off because of the lack of the time. So when you are presenting, you see all these findings when you are talking about it. Okay, go ahead. In this, is the consistent with your diagnosis or not?
There's not much LVH in this ECG, ma'am. P
You are
wave
not surprised?
present. Yes, ma'am. I'm quite surprised. P mitral is present. LA enlargement is seen. There are no signs suggestive of LVH or RVH.
What is the R by S in V1?
R by S in V1 is more than 1. So RVH is present, but LVH signs are not present in this ECG. And QRS axis is about plus 60.
So
What is the
Sir,
I mean,
please
why
say.
this ECG doesn't show LVH, even though there is probable LV enlargement? What is your explanation for that? The rotation of the heart?
Yes, sir.
Secondary pulmonary hypertension and right sided chambers enlarging. So rotation of the heart.
Yes, sir. Might be a possibility for no signs of LVH. So in this ECG, we have findings of LA enlargement and RV hypertrophy in this ECGs.
Axis?
Axis about
Right or left? You can tell that.
right axis, sir.
Right axis.
Yes.
So what does it mean?
Suggestive of RV enlargement and RV hypertrophy findings.
Can lead to pulmonary hypertension?
Secondary to pulmonary arterial hypertension.
So you want to put with the ECG, the first diagnosis in MS than an MRAR?
Possible from ECG, a possibility, ma'am.
Yeah, but usually MS will by this time will have a
AF,
little arrhythmias, which is not consistent with
not-
it. Okay, go ahead.
Yes.
So we have to explain why there is a lack of PCG changes of LVH.
Yes, ma'am. X-ray. Sorry for the poor quality of X-ray. X-ray, chest X-ray, PA view, situs solitus, levocardia, and there are from the X-ray there are signs of left-sided aortic arch, LV and cardiomegaly is present, LV type of apex, and pulmonary bay is full. There is straightening of the left heart border is present, and double counter sign is present, suggestive of LA enlargement. And signs of pulmonary venous hypertension is present, cephalization of veins and Kerley B lines are present, which are corresponding to our findings.
Yeah, I think if you go and ask what are the signs of an LA and what are the signs of an RA, all those things becomes very interesting. But because the lack of the time, the second time when we have another clinical case, we'll go more in detail of the X-ray finding. So this is consistent with your clinical diagnosis or not?
Yes, ma'am, it's consistent with my clinical diagnosis.
Is there any additional information you got it? You're not surprised that severe AR, there is no aortic, ascending aorta is not dilated?
Yes, ma'am, but maybe because of an acute regurgitation lesion, still the ascending
You have
aorta
not
is not
mentioned
yet.
any time in your case as an acute regurgitation. You are talking everything is for the acute rheumatic inactivity or infective endocarditis. Now you are suddenly brought in acute AR. Acute AR will have all the peripheral signs of the AR?
No, ma'am, it won't be this. I'm
Yes.
thinking acute and chronic presentation. Previously, it was mild to moderate AR, and now because
That
of the
causes the
rheumatic
decrease of the ascending aortic size. Patient already had a chronic AR, so now we had an acute, so that it causes the decrease in the aortic root size.
No, ma'am.
That is
Positioning correct? When you're reading this X-ray, first thing you should look at is the positioning.
No, it is rotated. It's a
Okay.
rotative film.
So you can't make very
Accurate findings from the rotated.
statements.
Yes.
Yeah, but there definitely you have to look for a aortic dilatation, which is not obvious though here. It may be due to either rotational effect or maybe due to the obstructive lesion in the upstream.
Yes, sir.
And there is a one question on the hemodynamics of bispherians. Anyway, we are going to have the one case next time we are having HOCM. That time we can tell in detail about the hemodynamics of the bispherians. Yeah, please go ahead.
You carefully observe the ascending aorta looks little dilated. You can see that little hump above the RA. So maybe because of the rotational effect, it's not that prominent.
Yes, sir.
Echo, you are presenting or
My colleague is presenting, ma'am.
Yeah. Dr. Naveen, can I have introduction of yours, sir?
Dr. Naveen here from Cochin Amrita Institute. Happy to join the discussion. And this was a total surprise and to me that such case of acute rheumatic fever do exist now also. Because I can frankly tell you, last 25 years I've been practicing cardiology and into the cardiology field. Right now I haven't seen the last case I saw an acute rheumatic fever. This is a reactivation. Last time I saw was an MBBS student. After that I haven't seen, and I am reasonably sure last 10 12 years we are our PG training, none of our PGs were able to see a patient actively having a arthritis along with something like a reactivation situation. So beautiful presentation, and going into the minute details of each clinical signs and eliciting how severe is this within a short span of time is something that is lacking in the training that is happening now. The went through it, and I was initially taken aback by the situation. A 22-year-old lady having already 3 kids and a BMI of 17 reflects the wide variation with which we see our patient subjects. And regarding your clinical presentation, excellent, right, except for few points that madam has told. This you have picked up most of the things, but I would like to put the diagnosis, final diagnosis, as something like a reactivation of a rheumatic fever. Since you told some 1 year back some history of admission with we didn't know the details of it, but it looks very well like a some acute element is there, because some arthritis was happened. So acute rheumatic fever reactivation with a severe AR and MR with a something like a carditis picture. So this picture can resolve. That is what the history wise like that. This picture can resolve. Need not be a chronic valvular heart disease where you need to take action. This can resolve something. That is what the hearing the story and clinical presentation. Otherwise, very well done. Unfortunately, I haven't made any slides for me to discuss with on this case, but very well done.
Thank you, sir.
I'll be happy to see the echoes, because you see the such a big heart, and how was that ECG? ECG has totally surprised you. The S you don't expect S rotation, everything, but this much of difference. So let us see how the let us see how the chambers look like. So each clinical science standalone will not tell much. Everything put together only we can tell the diagnosis. That is why you need multiple signs to come into picture, not your investigations, your ECG may something, your echo, everything has to put together. So right, one sign or one symptom, say, except you're focusing some time on Hill sign, that is one sign that can stand alone. Then your long drawn MDM murmurs, that can stand alone. Then sometimes your long drawn MDM murmurs, very short A to OS interval. There are few signs that can stand alone. Otherwise, everything in the interplay of polyvalvular, multivalvular heart disease will keep changing. So it will be interesting to see the echo pictures.
Before the echo is put up, sir, Soumya, sir. Sorry to interrupt. Sir, when during my DM in Amrita also, I've never seen any acute traumatic fever, sir. But once I've started working in Jaideva, I have a data of 100 children of acute traumatic fever in a span of 3 years. It is very rampant still in Andhra also. Here also we still see. We operate on mitral valves and double valves in children with acute traumatic fever. So it's still there. It's still out there.
మ్యామ్ స్క్రీన్ చేయాలి మేడం, షేర్ ఎలా చేయాలి?
Sudarshan, can you meanwhile, while presenting, tell the echo findings? If you're not able to present, we'll go to the discussion by Dr. Naveen Matthew. Dr. Roshni?
At least we wanted to know the
Yes, ma'am.
report of the NECO, because there is a disparity between the clinics and ECG.
While you're preparing, you may just present the lab data.
Sudarshan, you're new.
I haven't uploaded the lab data, sir, but I will.
Positive findings, whatever you know.
You can tell.
Okay. Actually, the patient's ESR and CRP positive, sir. ESR is about 45 mm of 60 mm of FG, and CRP is positive, more than 200. But failure was present, and HB was about 9, and rest all findings were normal, sir. And we have started her on steroids.
ASLO?
We don't have the opportunity, we don't have the means to do ASLO in our setup, sir. But we have started her on steroids based on the ASO titer and CRP and ESR values.
So what about aspirin? You have put him on a carditis dose of aspirin, or you just
Sir, we have started her on, because it's a severe carditis for the first 2 to 3 weeks. We have started her on only steroids, sir, 1 mg per kg body weight. And after 2 weeks, we'll overlap with aspirin and start aspirin. And continue aspirin for the next 12 weeks.
say if we don't treat this acute rheumatic fever, how long will it last? Natural history. Say she was lucky enough to come to your place and get treated. Somebody who is not that lucky enough, somebody having an acute rheumatic fever. What's the natural history? How long will it continue just like that, or will it subside in its own? You understood my question?
Yes, sir. More than 50, of the cases, more than 50% continue to chronic rheumatic fever, and with the above
Chronic rheumatic heart disease, chronic rheumatic fever. What is the message what is on your mind? Chronic rheumatic fever.
Chronic rheumatic heart disease, sir.
No. Forget about chronic rheumatic. Acute rheumatic fever, if it is undetected, say this is a stage of transition where people are able to approach you and get treated. There was a stage where this much was not happening. They were remaining in their villages with acute rheumatic fever. So what will happen to them? They can't continue to be febrile, and they can't continue to be having arthritis persistingly.
Sir,
You
arthritis.
understood my
Yes.
question.
Yes,
There
sir.
is a natural history for every disease.
Yes, sir.
Untreated natural history of acute rheumatic fever, how long will it last?
Sir, generally the arthritis will subside within 4 weeks without any joint deformity, sir. And the carditis, the rheumatic fever, carditis symptoms will subside in a month, and they have a high chance of.
It little more lasted. Up to 3 months it can last.
Yes.
Say if it become florid carditis and dies, that is another thing. Otherwise, all these activities will subside by itself within 12 weeks. Up to 3 months it can last.
Yes, sir.
Okay.
And
Your
they have
echo
high
pictures have started moving. I think.
Anyway, the echo already showed the severe MR, severe AR, and even TR is not shown. What is the severity of the TR?
Sir, madam, good evening, madam. TR jet velocity is a 3.1, madam. RVSP is a 49, madam. But TR jet area is 10.9, madam. It is a severe TR, moderate pH, madam.
LV dimensions?
LV dimensions is, sir, 5.5 into 4.0, sir. EF is 54, sir. FS is 27, sir.
There is some effusion already.
Yes, sir.
So everything tells you that there will be some acute element, and which can all these regurgitant lesions can improve with heart failure medications and your aspirin and steroids. Can you focus on the valve a little bit? Is it already reactivation or already?
Yes, sir.
Both are severe lesions. Both are severe.
Yes, sir.
But preserved. So there is reasonable LVH, though the ECG might have been overshadowed by that. LV might have been overshadowed by the RV.
Yes.
I think it confirms all the clinical signs.
Yes, ma'am.
Can we conclude the clinical or anything anyone want to add for it?
I think we'll go to the case, the presentation by Dr. Naveen Matthew.
Yes.
Madam, unfortunately, I haven't prepared any slides. I just thought I will join and discuss. So,
Okay.
Then you please go ahead, sir. What component you wanted, the clinical or echo, wherever you
So-
wanted to stop, yeah, please do it.
So what are the echo parameters? Now that you discuss, what are the echo parameters that will tell you that this is a severe MR? Just for academic discussion, Dr. Sanjana can.
Yes, sir. Because it's a multivalvular heart disease and both severe MR and severe AR are present. The independent variables such as vena contracta for MR and
How much was it?
it's more than 0.7, sir.
Right. So that is a clear data. You can just with that, that is usually one standalone thing to say that it is a severe
MR and
severe MR.
PISA values can also be taken and effective regurgitant orifice area can be calculated, which also gives a chronic severe MR in this case, sir. And coming to severe AR, values such as pressure half time is not reliable in this case because there are both regurgitant lesions which are severe. But vena contracta is a reliable
parameter of severity.
Of severity for severe AR, and effective regurgitant orifice area and regurgitant fraction can't be taken because of the both severe lesions. Two severe lesions, but vena contracta and diameter of LVOT, the how much percentage of the LVOT
occupied by the jet
is reliable, and effective regurgitant orifice area is reliable, sir. But regurgitant fraction is not reliable in this case for severity of AR calculation. And we have to take LV dimensions and EF, which is the most important variable to decide for the progress of the treatment, whether progress of the treatment and prognosis of the case also. LV dimensions for just the severe AR more than LV end systolic diameter more than 5 mm or LVEF less than 55 is a bad prognostic factor for severity of AR and MR combined in this case.
But this I think you have that acute element, so can hope that some improvements other than that chronic dimensions thing can happen. How much of aspirin will you give for this girl, for this lady?
Sir, 100 mg per kg body weight for the first.
It will be almost 4 grams.
Yes, sir. In 4 to 6 divided doses, we need to give, sir, along with along with proton pump inhibitors.
So there I am not aware how comfortable are they taking 4 grams of aspirin. They tolerate very well.
No, sir, they are very intolerant, but we give about 70 to 100 grams minimum, sir. In our area, rheumatic arthritis is still very rampant, sir. It is very epidemic.
And you with proton pump inhibitors, you are able to keep them on this much of aspirin?
Yes, sir. We give oral proton pump inhibitors twice daily. If they're not able to tolerate, we give IV also, sir.
This 4 gram means at least 1 gram every 6th hourly you need to.
Yes, sir. We give for at least first 2 weeks, 2 to 3 weeks. We give this.
And they tolerate. Oh, good.
They tolerate, sir. Mostly they tolerate, sir. About 50 to 70% they tolerate, sir. That's the rest patients.
Because it is available. Our largest tablet will be only 300
Yes, sir. They take about 12 tablets per day per dose.
Per dose.
Like minimum 6 tablets per dose we get, so.
They're not tolerating, you can just give the maximal tolerated dose.
Yes,
not be rigid on enforcing that.
Yes, we generally reduce up till.
We say it is self-limited.
Yes.
Yeah, that's also bring that because every effort should be there because this is the time that you can make some difference in the natural history. Once it becomes a chronic rheumatic heart disease, all what is symptomatic measures, you may not be doing much to the natural history.
Yes.
Are you aware of in the carditis, acute carditis, aspirin versus steroids? Any data?
So studies show that actually steroid is not very beneficial when compared to aspirin alone. But in most of the setups, we prefer to give steroids for 1 mg per kg body weight and taper for the next 6 weeks. Most of the studies they show that there is not much significant, there is not much
Additional benefit at the
additional
cost of a
benefit.
steroid side effect. That is,
Yes, sir.
then
But
practice varies. I can
most
understand.
of the setups in India, we give steroid for severe carditis.
So what do you feel, sir, Dr. Srinivas,
Regarding?
regarding steroids versus aspirin in the setting of acute rheumatic fever?
If I mean, if the carditis is in the scene, steroids. always.
Steroids.
That's all.
I think overall very good presentation, and in fact I have learned a lot of things.
Thank you. sir.
Very good guess. I mean, this regurgitation, double regurgitation of AR and MR, which both severe, is very hemodynamically very troublesome situation. Yeah. Basically, severe AR aggravates the effects of MR. I mean, they develop pulmonary hypertension, and the LV appears very normal many times. The severe hypertension sets in very fast. The MR murmur may be accentuated, while the AR murmur is not affected by the
MR.
mitral regurgitation. And yeah, so S3 will be present. That's more of a reflection of MR related features.
If there are no more questions,
Yeah.
can we conclude the class?
Yeah, I think so. It was a very interesting case, and nice to be part of this program. Thank you very much, ma'am.
Thank you,
Thank
Dr.
you.
Srinivas and Dr. Naveen Matthew, and
Thank you.
Dr. Jyotsna. And I thank my coordinators, Dr. Anupam and Dr. Soumya Kasturi, who made it a point to get in touch with Dr. Srinivas and Dr. Matthew. Thank you, Sanjana and
Thank you.
Sudarshan.
Thank you. ma'am.
Our next E-class is on Feb 27th. It will be congenital. It will be by Dr. Deepa S. Kumar. Okay. Bye.